Hey everyone, let's jump straight into this exam prep explainer. We are focusing strictly on high-yield COPD pharmacology today. If you're a fifth-year medical student gearing up for those exams, you are exactly where you need to be. Think of me as your personal pharmacology tutor for the next few minutes. We're going to break down exactly how the pathophysiology of chronic obstructive pulmonary disease literally dictates our treatment strategies. We are not just going to mindlessly memorize drug names, we're going to truly understand the why behind them. That way, you're not just going to crush your boards, but you're actually going to treat your future patients effectively. Here's our quick game plan for the session. We'll start with pathophysiology and inflammatory patterns, then hit our first-line pharmacological strategies. After that, we'll dive deep into the mechanisms, indications, and adverse effects, followed by a stepwise approach to treatment. And, of course, we'll wrap up with some high-yield exam pearls. All right, pathophysiology and inflammatory patterns. Before we can even think about prescribing a drug, we have to know exactly what we're fighting. What is actually going wrong inside a COPD lung at the mechanical and cellular levels? Okay, the central pathophysiological feature you absolutely have to have locked in for your exams is this specific sequential cascade. It all kicks off with a reduction in expiratory airflow because of small airway obstruction. But it doesn't stop there. This obstruction leads directly to air trapping. Because that air just can't fully escape when the patient breathes out, it builds up. And that buildup inevitably causes lung hyperinflation. It's this hyperinflation that is the main culprit behind the hallmark symptom of COPD, that's severe dyspnea or shortness of breath, especially when they try to exercise. Once you grasp this mechanical sequence, what we're trying to do with our bronchodilators makes total sense. Now, you really need to understand the stark contrast between the two main inflammatory patterns driving all this. COPD is definitely not a one-size-fits-all disease. First, we have neutrophilic inflammation. This is your most common form, driven by Th1 and Th17 pathways. It creates a highly oxidative environment, and crucially for exams, it is inherently steroid-resistant. Then, on the flip side, we have eosinophilic inflammation. This one is an alarmin-driven, type 2 immune response. Why do you care about this distinction? Because identifying that eosinophilic pattern completely flips your prescribing plan. Unlike the neutrophilic pattern, eosinophilic inflammation is highly responsive to steroids. Keep this difference in mind, it's practically the holy grail of modern targeted COPD therapy. Moving right along to our first-line pharmacological strategies. Let's look at the main weapons in our arsenal for managing these symptoms and reversing that airway obstruction and air trapping. Our absolute primary goal here is the symptomatic management of bronchoconstriction. To pull this off, we rely heavily on three main classes of inhaled meds: long-acting beta-2 agonists, which we call LABAs, long-acting muscarinic antagonists, or LAMAs, and inhaled corticosteroids, or ICS. Now sure, using just one of these can improve airway caliber, but in clinical practice, we're usually deploying them in synergistic combinations to get far superior results. And that brings us to a concept examiners absolutely love: pharmacological synergy. This is where medical math gets fun, and 1 + 1 actually equals 3. Combining a LABA and a LAMA works exponentially better than using either drug on its own. Why? Because they target totally complementary neural and smooth muscle pathways. You're attacking a bronchoconstriction from two totally different angles: the beta-2 adrenergic system and the muscarinic system. And the best part about synergy? It means you can often use lower doses of each individual drug. That significantly improves the safety profile and keeps your patients from dealing with those nasty, jittery side effects. So let's get into the nitty-gritty of mechanisms, indications, and adverse effects. It's time to get molecular, because understanding exactly how these drugs force smooth muscle to relax at the receptor level is exactly what differentiates a good student from a great one. For the boards, you've got to know the LABA canonical pathway cold. It starts with the drug activating the beta-2 adrenergic receptor right there on the airway smooth muscle cell. That activation triggers a spike in intracellular cyclic AMP, or CAMP. That CAMP then goes and activates protein kinase A, or PKA. PKA then gets to work reducing intracellular calcium concentrations, and as we know, calcium is absolutely required for muscle contraction. So a drop in calcium directly results in smooth muscle relaxation and bronchodilation. You've got to lock those 5 steps in. Now, let's talk about LAMAs. LAMAs fight constriction primarily by blocking the M3 muscarinic receptors, which, remember, are GQ coupled. Blocking M3 decreases inositol triphosphate and drops that calcium release, which relaxes the muscle. But here is the super high-yield secret you need to know. They also block presynaptic M2 receptors. These M2 receptors are normally GI coupled, meaning their job is to inhibit CMP. So by blocking them, LAMAs actually disinhibit CMP production. It's literally like taking your foot off the brake. By removing that inhibitor, LAMAs indirectly boost CMP, which beautifully enhances that beta-2 signaling pathway we literally just talked about. This crosstalk between receptors is the exact molecular basis for LABA/LAMA synergy. Okay, so what happens when we toss inhaled corticosteroids into the mix? The mechanisms of ICS are twofold. Genomically, they actually upregulate the expression of beta-2 adrenergic receptors, which makes your LABAs work even better. Non-genomically, they stimulate adrenaline synthesis. But listen closely, because the absolute highest yield concept for your exams here is the rescue mechanism. The intense oxidative stress in a COPD lung normally degrades an anti-inflammatory enzyme called HDAC2. This degradation is what causes steroid resistance. But LABAs swoop in like a molecular bodyguard. They inhibit the PI3K delta pathway, protecting HDAC2 from being destroyed. So the LABA literally rescues the effectiveness of the ICS in that hostile COPD lung environment. It's a brilliant tag team effort. So that brings up a crucial clinical question. When do we actually pull the trigger and add an ICS to a patient's regimen? This number right here is your clinical North Star. If you're reading a clinical vignette and you see a blood eosinophil count over 300 cells per microliter, that is your strong recommendation to add an ICS to their baseline LABA/LAMA therapy. That number tells you the patient has that steroid-responsive, type 2 inflammatory pattern we discussed a few minutes ago. However, you've got to pay super close attention to the contraindications, because ICS therapy is definitely not without its risks. You must absolutely avoid administering an ICS if the patient has a history of repeated pneumonias, if their blood eosinophils are stubbornly below 100, or if they have any history of mycobacterial infections. Handing out an ICS in these specific scenarios can severely suppress their local pulmonary immunity and cause major harm. Treat these as massive, blazing red flags on your exam questions. Let's shift gears to the stepwise approach to treatment. Let's see how all this molecular theory actually builds into a practical, modern clinical guideline. How do we take the pathophysiology and the pharmacology and turn it into an actual prescription? Categorizing patients is exactly how you should memorize clinical guidelines for the wards. You map your patient based on two distinct things: their exacerbation history and their daily symptom burden. If they're group A, they have very few exacerbations and low symptoms, they just get a single bronchodilator. Easy. Group B patients also have few exacerbations, but they have high dyspnea. They need dual therapy with a LABA and a LAMA to maximize that synergy. Then you have Group E. These are your frequent exacerbators. Their initial therapy is also dual LABA/LAMA, but this is the specific group where you must check those blood eosinophils. If they're high, remember over 300, you escalate them to triple therapy by adding that ICS. Now, as a future physician, you can never, ever forget patient adherence. Honestly, the most brilliant pharmacological plan in the world is completely useless if your patient leaves their inhaler sitting on their nightstand. A very common misconception out there is that a pill is always stronger or more real than an inhaler. You have to explicitly educate your patients right at the start of treatment. Let them know that inhaled drugs are incredibly potent, and they have the added benefit of delivering the drug directly to the target tissue with way fewer systemic side effects. Correcting this misconception early on is how you prevent poor compliance. All right, we made it to the final stretch. Key exam pearls. Let's synthesize everything we've just covered into a rapid-fire review. These are the absolute must-know facts that are basically guaranteed to show up on your test day. Take a mental screenshot of these first 5 points right now. They directly link the underlying pathophysiology of COPD to the receptor-level mechanisms we just explored. Remember that mechanical cascade? Obstruction leads to air trapping, which leads to hyperinflation. Remember that neutrophils stubbornly resist steroids, while eosinophils respond beautifully to them. And lock in those cellular pathways. LABAs boost CMP, while LAMAs block M3 to drop calcium and ingeniously block presynaptic M2 to actually enhance the LABA's effect. And here is the back half of those key pearls, focusing really heavily on drug synergy mechanisms and those all-important absolute contraindications. Understand that LABAs and ICS are best friends. The ICS makes more beta-2 receptors for the LABA to use, and the LABA protects the ICS from oxidative stress by inhibiting PI3K delta. keep that magic cutoff number of 300 eosinophils in your head for when to add an ICS. But aggressively, and I mean aggressively, guard against using an ICS if you see pneumonia or a mycobacterial history in a clinical vignette. I'm going to leave you with this final thought before you head back to the books. We've talked a lot today about broad groups and general guidelines, but as respiratory medicine continues to evolve away from a generic one-size-fits-all approach, how will you use these specific, treatable traits, like a patient's eosinophil count or their unique symptom profile, to truly individualize therapies? Grasping the pharmacology behind these traits isn't just about passing a test. It's the actual key to precision medicine. Good luck with your studying, keep reviewing those pathways, and you are going to absolutely crush it.